Hello, everybody. Today I'll be presenting my Neurodiversity Affirming Practice Reflection. I will be reflecting on key learnings I have learned in my course, the Neurodiversity Affirming Social Work Practice, SWCL 754. This semester, I've gained many key learnings in this course that I'm able to relate to my social work practice. The present reflection will explore and reflect upon my key learnings in the course, reactions to the social worker's attitudes towards disabilities scale, SWODs, and the implementation of my learnings to guide my current and future practices. Some of my key learnings from this semester include applying universal design principles to therapeutic environments, using neurodivergent affirming language, concepts, and contexts in therapy practice, and firsthand perspectives on behavioral interventions. This semester was the first time I experienced the universal design learning format fully integrated into a course's instruction. By experiencing this and through course resources, I learned how I can incorporate universal design principles in my field placement setting to make therapeutic environments more accessible and client-led. I also began to realize ways I have already been incorporating universal design into my neurodiversity affirming practice as a clinician. The basic framework of universal design is asking about accessibility needs. This can be done by asking about and providing options for sessions. For example, part of my practice as a neurodivergent affirming therapist, I encourage my clients, regardless of age, to engage with sensory toys to guide our sessions and to communicate in the way that works best for the client. So below are some depictions of some options I give my clients, specifically for my goals. The bottom left picture shows that it's really client-led, the goals for the session and for our work together. So sometimes words are hard. After our class week 2, I began to use an emoji joining/beginning activity with my clients to provide a visual option for sharing emotions and feelings in the session. This is part of universal design and helps clients identify and label emotions in a way that works best for them. So prior to this course, I felt a bit ill-equipped when using the language around neurodiversity concepts and contexts. Specifically, I often felt that if I used neurodiversity and neurodivergent terminology, I would be unintentionally offending a group. One of my key learnings from the beginning of the course was the recommended best practices of using and modeling affirming language. It is important for social workers to ask people what language and terminology is preferred and to avoid using neuroableist language. So, perspectives on behavioral interventions. Prior to this course, I had heard about the ethical considerations and challenges with behavioral interventions such as applied behavioral analysis and cognitive behavioral therapy for people with developmental disabilities. From firsthand perspectives on such behavioral interventions, important values in behavioral treatment include promoting positive outcomes, preventing harm, protecting autonomy, advocating for inclusion, sensitivity to past trauma, and supporting cultural competency. So from the Gardner reading on firsthand perspectives, a participant said, "It all goes back to consent. The power differential between the patient and the therapist needs to be taken into consideration. The patient needs to have a say-so in their treatment plan, and if they say no to something, the therapist needs to try something else." I'm also reflecting on how the implementation of these behavioral interventions vary, impacting whether or not behavioral interventions promote these supportive values, as mentioned previously. So now I'll be talking about the social worker's attitudes towards disabilities scale, the SWODS questionnaire. It is an important tool for reflective practice to challenge and uncover implicit biases in our neurodiversity affirming practices. The adapted SWODS includes 3 domains: cognitions, feelings, and practice, with a number of statements in each section. So here are some of my personal reactions. The second statement on the SWOD stood out to me. It reads, "Clinical treatment of people with IDDs, intellectual and developmental disabilities, may not be as productive as it is with neurotypical people." This gave me a pause to reflect on how we define successful or productive treatment. I was wondering what productive clinical treatment means or looks like. It is my understanding that productive treatment differs based on individual goals and client needs and is not a one-size-fits-all approach. Additionally, the statement under the feelings section, "When a client with an IDD comes into my office, I may feel uneasy," also stood out to me. Looking at the following questions, what if you can't always understand their speech, is a thought I personally have held many times. I am always worried about misunderstanding clients. This challenge or discomfort may reflect implicit biases or attitudes I hold about other aspects of a person's identity, such as religion or culture. By being conscious of these factors, I can develop greater empathy and work on my own communication skills. Lastly, I felt reassured when I answered the statement under the practice section. I wouldn't hesitate to make shifts in my practice to better support the people with IDDs. I feel that I act intentionally in my support for people with IDDs and create therapeutic environment that is client-led with options using a universal design approach, as mentioned before. As social workers, it is important to be aware of our behaviors. I would add to the SWODs a few questions about cultural competence and learning about other identities clients with IDDs may hold. This would be an important addition to capture identities related to cultural factors. This statement may look like, when conducting an intake session, I ask about the identities that are important to the person with IDDs. By identifying and acknowledging that I may hold an implicit bias about a person's culture out of fears that I may not understand my client and my motivation for promoting neurodiversity affirming practice, I'm able to address implicit biases by learning more about my client's identities, cultural backgrounds, and values. As a social worker, I can connect what I have learned about the concepts such as disability justice, neurodiversity, physiodiversity, and IDDs for this semester into my practice. I am committed to neurodiversity affirming practice. The SWOS reflective practice exercise allowed me to reflect on areas where I may experience challenges, discomforts, or biases. I will continuously check in with myself by engaging in reflective practice to guide my current or future practice. I can review the statements in the SWODs to check in with myself periodically about my cognitions, feelings, and practice. Another tangible way my learnings from this semester will guide my practice is the many excellent resources I have saved and often revisit, whether with clients or as part of my learning and continuous education. Applying the values of universal design, inclusive language, and neurodiversity affirming practices meaningfully into my clinical approaches and client interactions can strengthen the therapeutic relationship. In conclusion, I am committed to engaging in reflective practices in my long-term plans for integrating neurodiversity affirming practice. Throughout this course, I've gained valuable key learnings that will be implemented and incorporated into my future practice. Just as I took a creative approach in this assignment, I am motivated to commit to creative approaches in my practice. Thank you very much.